Separate views and projections were implied to visualize the carpal bridge and tunnel to demonstrate conditions that can be seen on the dorsal aspect of the carpal bones and the carpal tunnel syndrome, in which the median nerve inside the tunnel was compressed. Let's start first with the tangential projection for the carpal bridge. Again, when we see tangential projection, the path of the X-ray beam passes through a curved surface. There are two different patient positions for this projection depending on the required manipulation of the arm or the X-ray tube. They can be in standing or seated position at the end of the radiographic table. The recommended position for this projection is that the hand lie in the image receptor with palm upward and the hand is at a right angle to the forearm. This position requires a patient to stand at the end of the radiographic table. If the recommended position is too painful for the patient, we can perform an alternative technique where the patient can be seated by the end of the radiographic table with their forearm of the affected side is elevated and supported by sandbags, and then their wrist is flexed in right angle position with the IR plane in a vertical position. The posterior aspect of the hand should be in contact with the IR. For this projection, the central ray is angled at the 45 degrees caudal direction and enters to a point of about half inch proximal to the wrist joint. This could demonstrate fractures of the scaphoid, lunate dislocations, calcifications and foreign bodies in the dorsum of the wrist, and also the chief fractures of the dorsal aspect of the carpal bones. The next projection is for the demonstration of the carpal canal. It's the tangential projection Gaynor-Hart method, inferior-superior. When we say inferior-superior, it means that the beam will pass through the inferior aspect and exits the superior part. The patient will be seated at the end of the radiographic table for this projection. The wrist is placed in a hyperextended position with the digits being grasped by the patient's opposite hand or by a bandage to hold the position. Rotate the hand slightly towards the radial side to prevent superimposition of the shadows of the hamate and pisiform bones. The joint at the level of the radial styloid process should be centered to the image receptor. The central ray is directed at an angle of 25 to 30 degrees to the long axis of the hand, entering the palmar surface at a point of approximately 1 inch distal to the base of the third metacarpal. This projection will show the palmar aspect of the trapezium and the tubercles of the scaphoid, trapezium, capitate, hook of hamate, trichetrum, and the entire pisiform. Another tangential projection of the Gaynor-Hart method is in superior-inferior. In here, the patient is standing at the end of the radiographic table with their wrist in dorsiflex position at as much as possible. The patient should also lean forward so that the carpal canal will be placed in tangent to the IR. If dorsiflexion of the wrist is limited, a 45 degrees sponge wedge may be placed under the palmar surface of the hand to slightly elevate the wrist to place the carpal canal in tangent to the central ray. This technique was suggested by Marshall. The central ray is angled towards the hand at approximately 20 to 35 degrees from the long axis of the forearm, in a tangential direction to the carpal canal at the level of the midpoint of the wrist. This projection shows the same structures as shown in the inferior-superior projection of the Gaynor-Hart method. The next projection will demonstrate the entire forearm. For the anterior-posterior projection, the patient should be seated close to the table low enough to place the entire limb in the same plane. The elbow is extended with the hand in a supinated position. To achieve a true supinated position of the forearm, have the patient lean laterally. The central ray is directed perpendicular to the midpoint of the forearm. This projection will show the wrist, elbow joint, and the distal humerus. A slight superimposition of the radial head, neck, and tuberosity over the proximal ulna will also be visualized. For the lateral projection of the forearm, have the patient sit low enough close to the table to lie the shoulder joint, humerus, and elbow on the same plane. The elbow is flexed 90 degrees to place the forearm in lateral position, and the thumb side must be up. The central ray is directed perpendicular to the midpoint of the forearm. This projection will show the entire forearm, including both elbow and wrist joints in lateral. Superimposed radius and ulna at their distal end, and then superimposed radial head over the coronoid process, superimposed humeral epicondyles, the radial tuberosity facing anteriorly, and the elbows flexed in 90 degrees will also be visualized. For the AP projection of elbow, the patient is seated sideways beside the radiographic table, low enough to place the shoulder joint, humerus, and elbow joint in the same plane. The elbow joint is extended and centered to the IR with the hand in supine position. To make the humeral epicondyles and the anterior surface of the elbow in parallel with the IR plane, have the patient lean laterally. The central ray is directed perpendicular to the elbow joint. This projection demonstrates the radial head, neck, and tuberosity slightly superimposed over the proximal ulna. The next projection for the elbow is the lateral projection. Again, the patient is seated low enough to place the shoulder joint, humerus, and elbow joint in the same plane. The elbow is flexed 90 degrees and the humerus and forearm is in contact with the table. There are two reasons that was given by Griswold regarding the importance of elbow's 90 degrees flexion for the lateral projection. First is to see the olecranon process in profile, and the elbow fat pads are least compressed. To fully obtain the lateral projection of the elbow, adjust the hand in lateral position and ensure that the humeral epicondyles are perpendicular to the IR plane. The central ray is directed perpendicular to the elbow joint. This projection will show an open elbow joint centered to the central ray, elbow flexed 90 degrees, superimposed humeral epicondyles, the radial tuberosity facing anteriorly, and the radial head partially superimposing the coronoid process and the olecranon process in profile. Visualization of posterior fat pad in a properly flexed elbow for lateral projection indicates a pathology. The next projection for the elbow is AP oblique projection. It has two positions, the medial rotation and lateral rotation. Let's discuss first the AP oblique projection in medial rotation. The patient is seated at the end of the radiographic table with their arm extended and in contact with the table. Since this is an oblique projection, we have to place the anterior surface of the elbow in 45 degrees obliquity. To obtain this, rotate the patient's hand internally or medially until it is in prone position. The central ray is directed perpendicular to the elbow joint. This projection and position demonstrates the coronoid process free of superimposition from the radial head. Next position of elbow's AP oblique projection is in lateral rotation. The same patient position in which they are seated at the end of the radiographic table with the entire arm of the affected side is extended and in contact with the table. To obtain the 45 degrees obliquity of the anterior surface of the elbow, rotate the hand externally or laterally from supine position. The central ray is directed perpendicular to the elbow joint. This projection will visualize the radial head and neck free of superimposition of the ulna. When the elbow joint can be fully flexed, two AP projections can be performed in partial flexion. First is to include the distal humerus. For this projection, the patient is seated sideways at the end of the radiographic table, low enough to place the entire humerus on the same plane. The elevated forearm should be supported. If possible, place the hand in supine position. Place the IR under the elbow and center it to the condyloid area of the humerus. The central ray is directed perpendicular to the humerus, traversing the elbow joint. This projection shows the distal humerus when the elbow cannot be fully extended. The next AP projection in partial flexion is to include the proximal forearm. The patient is seated at the end of the radiographic table. Seated high enough to permit the dorsal surface of the forearm to rest on the table. Direct the central ray perpendicular to the elbow joint and long axis of the forearm. This projection can demonstrate the proximal forearm when the elbow cannot be fully extended. When fractures around the elbow are being treated using the Jones orthopedic technique, where the elbow is in complete or acute flexion, the frontal projection must be made through the superimposed bones of the AP arm and PA forearm. Let's start first with the projection for the distal humerus. So the patient is in seated position at the end of the radiographic table with their elbow fully flexed. Center the image receptor proximal to the epicondylar area of the humerus, and the long axis of both arm and forearm should be parallel with the IR's long axis. The central ray is directed perpendicular to the humerus and enters to a point approximately 2 inches superior to the olecranon process. This position will visualize a superimposed forearm and arm, and the olecranon process is clearly demonstrated. Another projection when the elbow is in complete flexion is PE projection for the proximal forearm. The patient is seated at the end of the radiographic table with the humerus in contact with the table and elbows fully flexed. The central ray is directed perpendicular to the flexed forearm, entering approximately 2 inches distal to the olecranon process. This position will show an outline of superimposed bones of the arm and forearm, and also the elbow joint should be more open than the projection for the distal humerus.